I think NAFLD, or today we call it as MASLD, is a huge problem. One, because of the fact that diabetes is now increasing in prevalence. In fact, we would be unofficially called the diabetic capital of the world. Number two, we are going to face what we call as a tsunami of diabetes and tsunami of NAFLD, or a steatotic liver disease. Now, if you look at 100 patients with diabetes, around 80% of them would be expected to have a fatty liver on ultrasound. Of these, 30 to 40% would have what we call as metabolic dysfunction associated steatotic liver disease, or what we used to call as non-alcoholic fatty liver disease, with or without steatohepatitis. Now, the problem is not that. The problem is that many of them show a tendency to progress fast to more severe forms of liver disease. And therefore, the challenge is to find out which are the patients who are going to progress fast. For example, a patient who's got other comorbid features or factors like obesity or hypertriglyceridemia, or alcohol intake, or a family history of a liver disease. These are people who are at increased risk of progression. So, you roughly around 10 to 15% probably would progress on to more severe forms of liver disease. And therefore, in answer to your question, I believe it is a major problem. A lot of patients we are going to face with non-alcoholic fatty liver disease, and of these, a lot of them would require investigations and intervention. In my practice, actually, I use FIB4 and the APRI quite commonly, and also the NAFLD activity score. Why? Because the variables used in the calculation, all of us have got mobile, all of us have got access to the net, and it's very easy to look up the mobile and go into the app and then calculate, get a reading for FIB4 or APRI or the NASH activity score. All of them, each one of them will give us a rough idea about whether this particular patient is likely to go into more severe forms of liver disease. Now, I think we should keep in mind that what do we need? The variables we need to calculate all this is simple. We need the BMI, we need the ALT, we need the AST, we need the platelets, and once you have these four, and also in addition to that, some of these apps, some of these may require age, as well as whether they are diabetics or not. So it's so very easy to calculate these variables, and we can build up algorithms based on these variables and determine whether a patient is at A, high risk for progression to more severe forms of liver disease, B, which category or which block which this patient falls into, and whether the patient requires intervention or not. UDCA had come up in a big way. We have been using UDCA in patients with liver disease, almost all forms of liver disease. As far as NAFLD is concerned, I believe we don't have enough or strong evidence to back the use of UDCA in patients with non-alcoholic fatty liver disease, and therefore, to be very frank, my use of UDCA in patients with non-alcoholic fatty liver disease has definitely come down. Probably at best it improves the transaminases, but I'm not too convinced that whether it affects the natural history or decreases the fibrosis. Maybe I would look at four sets or four subsets of patients. Number one, is you look at a patient who is a diabetic, ultrasound shows evidence of a fatty liver, has got a mild elevation of transaminases, maybe has platelets that are slightly low. This is a classical case of a patient who is likely to progress and an indication for saroglitazar. The second is a patient with diabetes who has got hypertriglyceridemia and a fatty liver with or without abnormalities of liver chemistry, specifically ALT or AST. This is the second category which will demand or the use of saroglitazar. The third is a patient who need not be diabetic, who is obese, who's got features of metabolic syndrome, has got abnormal liver chemistry, again an indication for saroglitazar. And the fourth, the patient is not a diabetic, has got fatty liver, has got altered chemistry, may or may not have hypertriglyceridemia, may have other risk factors like family history. That is another patient where I would use saroglitazar upfront at a very early stage. Two ways, two parts to this answer. The first part is what can I expect in a patient who is put on saroglitazar? I expect the patient to normalize the ALT and AST, and that happens quite fast. It happens actually within 4 weeks. That has been my experience. Second is the triglycerides also come down, so it's got a beneficial effects on triglycerides. It has got a beneficial effect on the steatosis index or the CAP as we calculate, which we actually look at the fibroscan, and most of the machines today actually give out a CAP value also. It gives a rough estimate of the amount of fat. I found that that also improves. As far as the fibrosis is concerned, yes, in some I have got patients who have improved, say from F3 to F2 or F1, or some of them from F2 to F1. So there seems to be a trend towards decrease in fibrosis as well. As far as the natural history is concerned, I don't think I have enough data, but then if you go by the history, by whatever has been published in literature, there is some indication that yes, there may be a trend towards a global improvement in patients with non-alcoholic fatty liver disease. Whether that translates to a decreased progression to cirrhosis in patients with high risk, or the patient in the long run improves overall, is something that needs to be seen.